we checked it before, and it seems that all was working well. Anyway, I tried to recover the time spent for technical reason. So I would like just to introduce the topic of proton and carbon ion therapy in general, and immediately after to speak about some very preliminary data in breast cancer. As you know, as a radiation oncologist know, our goal is from since the beginning to have a high degree of conformability. That means that we have to give the dose exactly in the target, avoiding the organ at risk. And in the past year, there is an increasing interest in using, in addition to conventional X-ray, to use particles, hadrons. Hadrons are particles made by at least 3 quarks. There is a lot, it's a big family of particles, but currently in clinical setting, the most used hadrons are protons and carbon ions. And in the past also, neutron has been extensively employed in clinical setting. Hadron therapy is a quite new word. 20 years ago, has been used for the first time. Currently is used mainly in Europe, but before and currently in other countries, also you can find this kind of therapy described as EV particles radiation therapy, particle therapy, neutron therapy, proton therapy, in the case of Japanese colleague, carbon ion radiation therapy, the CERT. What is the main advantage of hadrons, of carbon ion and proton? Is the capability to have a really very high level of precision in hitting the target. You can see here the small bowel of the mice. You can see that in the upper part, the crypt are totally conserved. In the lower part are totally destroyed. This is possible on a millimetric basis because we have a sort of knife that cut absolutely with high precision our target and give the dose, put the dose into the target. This is the dose distribution that is already well known and presented also by Professor Gerard before. And you can see a very typical Bragg peak that is very similar, depends from the energy, from proton and carbon ion. Probably carbon ion is more advantageous in terms of lateral spread of the field. And but the peak Bragg is very narrow, is very strict, and if your target is not mosquitoes, but it is a tumor, we have to enlarge the Bragg peak using different sequence of multi-energetic peaks. This means in clinical practice that you have less advantage in the corridor of entrance and remain the same dose distribution at the end of the peak. So this is just to show what means physical selectivity. Is a comparison between the gold standard with X-ray therapy, like EMRT or stereotactic irradiation, with hadrons, in this case proton beam therapy. You can see that the coverage of the target is approximately the same, but what is really important that you can obtain this goal avoiding a lot of normal tissue irradiation. So that means that you are able to increase the therapeutic window of the treatment. This physical selectivity is a characteristic, as I said, of proton and carbon ion. In addition, carbon ion and neutrons too have also a so-named biological selectivity. That means that they are high lead particles and have a modality to give the dose in a short track. This allows to break the double chain of the DNA more frequently with respect to the sparse radiation of X-ray. This characteristic that is evaluated according to a number that is effectiveness radiobiological, effective radiobiological value can range for carbon ion and neutrons in a value between 2 and 5. That means that we can apply the same physical dose, but we have a biological effect that is normally at least 3 times more with respect to X-ray or other low-lead irradiation. For this reason, normally carbon ions and neutrons are poorly related to the hypoxia that often is present in the tumor, seem not to be related to the phenomena of the DNA repair, and also is not so related to the cell cycle phase. For this reason, high lead particle carbon ion are suitable for so-named radio-resistant tumor. Radio-resistant is a complex phenomenon. There are some causes for radio-resistant for genetic alteration, upregulated oncogenes, mutated tumor suppressor genes, apoptosis, dysregulation in apoptosis. Also, another important issue in radioresistance is the intratumoral micromilieu, that deprivation of oxygen, upregulated defense system, and the high angiogenetic potential of the tumor. And again, radioresistance can depend on proliferation status, and high lead particles are effective, especially when the cell population contains a lot of quiet cell clones or in tumor that are slowly proliferating. And also in breast cancer, as in other tumor, most of this condition can be present. From the clinical point of view, we have data in the past 50, 60 years, and today we can say that thousands and thousands, more than 60,000 patients has been treated with proton therapy. More than 20,000 patients has been treated with neutron therapy, and about 7,000 patients has been treated with carbon ion therapy, mainly in Japan, and more recently in the 2 European centers, one in Germany, in Heidelberg, and the other one in Italy, in Pavia. There is also an increasing interest in scientific environment about the publication on hadron therapy. And if you look in the PubMed and do use particle beam therapy, you can see that in the period between 95 to 99, we can get 68 papers that increase to 93 between 2000 and 2003, about double between 2004 and 2007, 162. But really more recently, since 2008 up to date, we can find more than 500 papers in which great majority, a good number, 160 are related to the clinic. This means that now we are more centers available to perform hadron therapy, proton mainly, big success in the United States, but in every part of the world there is a big interest in creating this kind of center. And what it is expected is due to this great availability with respect to the past, to can treat more and more patients, and important point, to produce evidence-based medicine in favor of hadron therapy, if any. This is a situation in Lombardy, in Italy, in the north of Italy, close to Milano. My institute is a European Institute of Oncology, and very close is TECNAO, the National Center of Hadron Therapy. I manage both of the center. The building, the institute has been finished on February 2009. You can see here the layout of the institute. a synchrotron has been built. It's homemade synchrotron. It's not industrial product. And this machine has been designed of the project of the CERN in Geneva. Very huge ring, more than 120 meters of circumference and 22 meters of diameter. This synchrotron is able to accelerate both proton up to a maximum energy of 270 MeV and also carbon ion to a maximum energy of 400 MeV per nucleon. That means a total of more than 4,500 MeV. We have the beam in the room at the end of October 2010, and we have treated the first patient the 22nd of September of 2011. You can see here one of the 3 treatment room with a robotic coach and imaging system. Obviously, the tools that you need to realize this high precision therapy have to be more sophisticated with respect to conventional X-ray therapy, and unfortunately also more expensive. Typical indication is based on the skull tumor. You can see an example. We started with this kind of tumor. Just an example, very fast, of chondrosarcoma, grade 2 chondrosarcoma in a young man, 27 years old, recurrent after 2 surgical operations. And this is the setup of the patient. We have also a system to set the right position of the patient using both images, X-ray images, and also infrared system guided by real-time cameras. This is the dose distribution that can be obtained using proton beam, and this is an interesting issue because there are no possibility to have a portal view, a conventional portal view, but you can follow the activation of the molecule along the tract of the proton or carbon ion beam, and you can register this activity immediately within 15-20 minutes after the delivery of the dose using a PET scan without any administration of contrast media, obviously. The ideal situation is to have the PET into the room in order to have a real-time evaluation of the track of the beam. As I said, we started with carbon ion, and this is a classic with the skull-based tumor, but also there is also other emerging indication. One of these, not the more frequent, to be honest, is breast cancer. The interest in breast cancer is due to some consideration like this, published from the colleague from Gothenburg, Uppsala, and Stockholm in Sweden, in which they observed in 2005 that the tumor control is unaffected in breast cancer using proton, but really important, and Dr. Tagian already stressed this point, the risk of serious cardiac toxicity is reduced by 76%, from 2 to 0.5%, and the risk of pneumonitis is also by 96%, from 15% to 0.6%. And they estimated, this colleague estimated that about 10%, not for all, but 10% of the patients currently treated in Sweden should be potentially eligible for protons. That means patient at left side breast cancer, patient younger, patient with concurrent cardiac disease. There is also some theoretical study because the number of patients effectively treated with breast cancer is very low, in which has been demonstrated, like in this paper produced in the center of the Paul Scherrer Institute in Villingen, in Swiss, in which that if you have to preserve, comparing different technique, X-ray plus electron, different approach with dynamic EMRT, if you like to preserve the target dose homogeneity, the only option to reduce the dose delivery to the both lung, to the heart, and to the contralateral breast is using proton. This has been confirmed later on the same group in 2010 in a paper on the Red Journal, and also very recently has been reported one patient treated for oligometastatic inflammatory breast in the Proton Center in Houston, Texas, and a very recent paper in which the combination has been used for this patient, a combination of proton, photon, and electron therapy. Jean-Pierre Gerard mentioned partial breast irradiation. As you know, partial breast irradiation is a concept. You can use a lot of different techniques to realize in clinical setting this concept. Some of them are invasive, others are considered not invasive. And among the external beam therapy option, there is also the use of protons. This is the schedule, the scheme, the setup that I normally use it in Boston, but I cannot discuss all that because the true expert is Alphonse Tagian, and so I have no additional thing to do on this topic. What I can add is that there is also other paper that comparing different external beam partial irradiation technique confirm that the maximum saving of non-PTV breast, lung, and heart is achieved much better using protons. Recently has been published in another center, I think only two centers in Boston and Loma Linda, has been activated protocol for partial breast irradiation with proton. And quite recently, Dr. Bush and colleague in the Loma Linda University published the first preliminary result on the first 50 patients treated, typical schedule of partial breast irradiation, 40 gray in total, in 10 fraction in 2 weeks. And you can see that you have a good overall survival, good disease-free survival, and they observed only one ipsilateral breast recurrence after 5.5 years from the treatment. Another important point is that they not observed grade 3 toxicity. Skin may be an organ at risk with proton more than with X-ray, and also telangiectasis is very low incidence and only of grade 1. What about high lead particle? There are no experience in Japan in applying carbon ion in breast cancer, at least up to date. There is only a paper on the use of high lead particles. It's referred to neutron, and Australian Oncology, German journal, on 2005, colleague from the center in Cape Town published this paper in which they are used neutron versus photon radiotherapy for local control in not operable breast cancer, limited number of patients, 27, and they did not observe any advantage in use neutron therapy with respect to conventional, both in terms of local control and also in terms of toxicity. One of the major points of hadron therapy is the cost. Is the cost, because the question is how much does it cost? And in 2012, 1 year ago, in the New York Times, journalists defined the reimbursement for proton therapy as a model for crazy medicine and unsustainable public policy. I believe, because I am strongly involved, but not only, that we have also to consider other aspects, not only local control and overall survival, that are absolutely primary and the most important endpoint, but also we have to consider the quantification of the normal tissue complication, because it is equally important, especially today that it's possible to observe very long-term survival after cancer therapy. So just to conclude with a few data that I was able to show you, is a list of field of possible research in breast hadron therapy. To continue to have a model, and we are working on that in my center, in comparison between proton therapy, carbon ion therapy, and also helical tomotherapy or dynamic EMRT, in order to create a sort of atlas of map distribution. We have to look at the late effect and how we can save the patient or spare the patient from the incidence of light effect with respect to X-ray. I believe that proton may be, since today, applied as a technique, acceptable technique for PBI and also for boost in the patient in which boost to the tumor bed for patients that are indicated to be treated with this overdose of irradiation. I think that the subject of interest in clinical setting is the use of, I believe, also carbon ion in locally advanced breast cancer in the primary, but we need a selection by biological subtype. And another field application that is the only that we are using now in Pavia, we have activated a protocol for the treatment with carbon ion of metastatic disease in the orbit in women with breast cancer, mainly for choroidal metastasis. We have treated really few cases, 3, but obviously we have to wait from some result with a longer follow-up. Thank you very much for your attention.
Thanks, Dr. Professor Porto, for this very nice presentation about the use of proton and carbon ion therapy in breast cancer with good results and nearly no toxicity. And now our Professor Dr. Salah Al-Misini will present the next speaker.
The final presentation of this symposium will tackle a common problem we all face during our practice.
ده مش ممكن يحصل ده عشان تصلحوا غلط تعملوا غلط. التأخير المعقول ده اوفر جدا كراودد والناس مش عارفه تقف. يعني هو المصريين دايما كده